stay tuned for Q&A. We're going to do it right now. And also we have a few questions left that people typed in the chat. Okay, this is from Debbie. I have disc and stenosis issues. I'm in constant pain. I've seen numerous doctors. I'm on meloxicam and gabapentin. Neither work. Now my hands are arthritic. Is this all related to the ATTR wild type or is it structural? My life is a recliner.
Yeah, that's terrible. I'm sorry to hear that. Again, I think we discussed whether, these problems are common among the general population. It's unclear if it's gonna definitely be related to the wild type amyloid. The only way to really prove that is to do a biopsy. But at the end of the day, you do need to get some sort of treatment, maybe refer to a spine center and trying other type of medication. I don't know all the details of your medical history, but yeah, I don't think you should be suffering.
From Todd, I was diagnosed with stage 1 wild type in March and have been on Vyndaqel and now Vyndamax since then. What is your opinion on adding green tea extract to my treatment program? My doc at Mayo was on the fence back then, wondering what others think about it. So we'll start with Dr. Sperry and then adding green tea extract. What do you think?
Yeah, so, before tafamidis was available, we used a whole bunch of concoction of different medications that had more soft evidence behind them we saw through many of the presentations the cascade from the protein misfolding and then depositing in the tissue, so that different medications can work at different parts of the cascade. And so you have green tea extract, which has an active component of EGCG, curcumin, turmeric, doxycycline, TUDCA. So all these work in different spots, and there's, the evidence is more soft. There's not randomized clinical trials, double blind with hundreds and hundreds of patients looking at hard endpoints for these. So some patient, I don't think they interact with any of the other medications that we have here. I think the medications that are approved, the silencers and the stabilizers really are going to do the most heavy lifting as far as decreasing the amyloid burden. And so I have some patients who do want to continue taking those, and I think that's fine, but it's unclear what the added benefit is.
Anyone strongly agree or disagree here? Okay, thank you. From Woody. For wild type, are there other medications in addition to Vyndaqel one should be taking? Is nerve damage both inevitable and progressive in either type? Dr. Karam?
Yeah, I think we've discussed the issue of nerve. Again, neuropathy, there's many different reasons why people get neuropathy. These need to be ruled out first. There are also mimicker of neuropathy, such as spinal stenosis. So refer to a neurologist to study exactly what's going on. Again, we don't know for sure if wild type also caused neuropathy or not at this time.
Okay, this one, I don't know whether UPenn or St. Luke's was going to be involved or is involved in the Prothena X4 drug, but this is a question referring to the drug that would remove amyloid deposits from the organs. So, they were just in phase 1 on that. Anyway, they wouldn't have had any data, or did they have data and I haven't seen it?
Yeah, so I was the primary investigator when I was at Oregon on the Prothena study. The data is not public, so I cannot discuss it, unfortunately.
Okay. And Dr. Sperry just mentioned the other things like doxycycline and EGCG are more anecdotal than anything else. So I guess right now we don't have anything that really we know will work on removing the amyloid from the organs, right? Okay, from William. No, we did William. Okay, never mind. From Diana. My husband has an odd numbness and pain on the outer side of his left hand with normal ulnar nerve conduction. Can this be a symptom of ATTR or the Vyndamax? The pain wakes him at night.
Yeah,
So,
it's unlikely, but doing careful nerve conduction study, looking if something coming from the neck, whenever you have something so localized, it's not usually amyloid. Amyloid is a little bit more diffuse.
okay. Okay, here's someone asking about the ProBNP test. Is it a good indication of how the heart is doing? So we were just discussing earlier where someone was saying that perhaps it was a better scale for the AL rather than the TTR. How are you feeling about that, Dr. Sperry?
Yeah, it's a challenging endpoint because you can have a patient who has an NT-proBNP of whatever 5,000, say, and they come into the hospital with fluid overload, and then you give them a diuretic, and then it goes from 5,000 to 2,000, in 2 days. And so how using that as an endpoint in a clinical trial is just can be very difficult, especially when multiple things are going on at the same time. You can give a stabilizer or silencer for a year, but during that time, their BNP can fluctuate dramatically over the course of the year. And so it's one of the issues that we've spoken about today is we don't have really good biomarkers to let people know, that they're feeling better, or not that they're feeling better, but that they're doing better over time. So we use what we have, and BNP is one, and certainly with AL, we see patients when they get diagnosed, BNP, NT-proBNP, very, very high, and then if they're in remission for 2 or 3 years, it can be very low, and then if it's coming back, the amyloid, you can see it rise again slowly. So that's a good more of a better biomarker, more consistent for AL, I would say, and for ATTR, it's very, very difficult. It can be up and down.
Thank you. Okay, clinical trial questions. Here's one for, I have a solid lesion, most likely a renal neoplasm in my kidney that was diagnosed in the spring of 2019. It's checked twice a year and has remained at 1.5 centimeters. I've been told that since I have this, I can't qualify for any of the silencer drug clinical trials. Okay, I have wild type. Any suggestions? Okay.
Muriel, it's not unusual for trials, especially phase 3 trials, registrational trials, to prevent patients with other malignancies or malignancies to be on the trial, considering that now we are going to have to deal with 2 diseases, right? So it's not only the malignancies, but other comorbidities that frequently we prefer not to have that patient in the trial to prevent noise in the results. Of course, that later when the drug is launched, if launched successfully, the patients with all those comorbidities also can use the drug for the benefits, right? It's not because you're not in the trial that the drug is not for you. But I understand that this person may face some criterion suggesting that this person cannot be enrolled in the trials due to that malignancy that's being followed on. So this is something general in clinical practice for clinical research. It's part of the good clinical practice in specifically for the protection of the patients. So I think this is something that, it's going to be a problem for the trials.
Okay, and Stephen?
Agree with everything Gustavo said.
Okay, that was easy. Okay, another one for Gustavo. Why can't you take doxycycline with vutrisiran?
Vutrisiran, so probably Roblin?
Yeah, so again, so vutrisiran right now it's essentially a similar discussion what we just had with Gustavo, which is, vutrisiran's in an investigational phase, and what we're looking to do in those types of phases is try to understand as clearly as possible what the investigational drug, in this case vutrisiran, is doing to the patient versus the control group. And what you ideally would like to try to do is do that, in as quickly as possible with the least number of patients. And the idea there is then you get the drug approved quicker and you can get it to more patients. So doxycycline, because again, it has a potential mechanism in amyloid, but doesn't have the data associated with it yet. That would be the same as say tafamidis in terms of indication and sort of phase 3 evidence. We wouldn't be allowing co-administration in a clinical setting. But again, I think back to what Gustavo just said is once these drugs are approved and they're available, then these sort of concomitant uses could become more common. And again, that would be based on other data that comes out and perhaps the judgment of the physician based on, you know, a multitude of other factors. And we know that that's happening right now with other things.
Okay, this is more from the gal that asked that question, Edie. I'm also involved in the Cardio Transform trial, and I'm coming up on week 16. If I'm getting the real study drug, how might that color or mask any improvement from the tafamidis? I know that the tafamidis is a stabilizer and the study drug is a silencer, but is there any way to know which drug is doing the heavy lifting?
Oh, that's a great question. And well, we hope at the end of the trial, we will be able to shed some light on that question, right? So as Steve properly put here, when you're doing a clinical trial, you have to try to avoid having other medications acting in the same disease unless you're never going to be sure what's happening or not. But at the same time, in the tafamidis situation, we cannot prevent the patients to take it because that would not be ethical. So we get in that great question that we can only answer at the end of the trial. At the end of the trial for Cardio Transform that this patient is participating, we will have all the data on the patients on tafamidis, not on tafamidis, placebo, or the TTR-LICA. Of course, these are subgroup analysis. This is exploratory analysis. We're probably not going to be able to bring evidence, but very good trends and understanding for this area. And of course, maybe opening more hypotheses for future studies. So I think Cardio Transform will be able to shed a lot of light in that question because we are using a lot of silencers and stabilizers together. And I hope I'll be able to bring something better in a few years for you.
Thank you. Okay, from Carol. I'm in the Apollo study, stage 3. I've had 2 infusions. Next week will be the 3rd. I have osteoporosis and should take reclassed. Would that be a good idea?
I can't certainly comment on that just from a medical perspective. You know, we have, of course, within the study, there's certain exclusion criteria for entering based on medications. That's not one of them. So I would say she should probably certainly talk to her doctor, and if they had any additional questions about potential interactions, again, like has been said before, we have a medical information function within Alnylam, and we can do some research and perhaps give a more definitive answer.
Okay, she has another question. Should I be noticing any positive effects in my breathing?
Right. Again, I think this is one of the challenges that we're all kind of talking about here, which is in these clinical studies, you know, and I think maybe more now that we have these sort of second generation medicines where, you know, we had a first generation medicine, you know, say an RNAi or an ASO or stabilizers that showed some benefit, and then we're doing these follow-on trials with different medications, and there's sort of this inherent expectation that they may be doing something, which of course is what we all want to have happen, but the reality is we're still in the investigational phase, and you know, we don't really have any idea how vutrisiran in this case, but I think we would say for any investigational medication, how it's going to react to the patient, what sorts of effects we would see, for how long, and in what types of patients, and that's the reason we're doing these studies. So I would, for Carol, I'm happy that she's had an opportunity to participate in the study, and I really, you know, like everyone, hope for the best and hope that she sees, you know, as positive effects as possible.
Thank you. She wants to know if a glass of wine would be harmful.
I won't comment on that. You know, I think we had a comment earlier about neuropathy certainly and alcohol, but from Dr. Karam, but
she's got osteoporosis, so
I won't comment. You can say that, Muriel.
I will say that.
All right.
Okay. No, don't say, I didn't say that. Okay. Here's something for everyone. Okay, from Harry. How do you, okay, never mind. That one was asked. That one was asked. Okay. Okay, the goal of any medication is to extend the life and quality of life of the patient. What is the expectation for your medication versus not taking your medication? Anyone want to tackle that?
Yeah, so I think again, it depends on what we're talking about. Are we talking about medications that already have, say, phase 3 data that are approved? And in that case, I think we have, and we talked a bit about it today, some pretty clear data on what patients should expect and not expect. And again, you know, every patient is different. We see, you know, within these studies, we see we always report on the mean change in patients and how many patients on average did this or that. But the reality is every patient is unique, and some patients may see improvements in some areas and may not see improvements in others. And that's the nature of even the data we have for drugs we've already studied. And then again, back to what I said before, which is for drugs that we haven't studied as much yet, you know, we design these studies and we look at outcomes based on what we expect to happen, and hope to happen, of course. But again, we don't really, it's very difficult to sort of make any definitive statements on again, what patients should or shouldn't expect.
Okay, let's wrap this up, okay, with one final question before we say farewell, okay? And that is the elephant in the room, COVID. Okay, we received numerous questions about COVID. Am I in a high risk category because I have hereditary or wild type amyloidosis? Should I take the shot when it's available? Should I not take the shot when it's available? What are your thoughts on whether it's safe or not? So, you know, every question that you can imagine about the shot, the vaccine has been asked. So, Dr. Sperry, what are your thoughts on the COVID vaccine for our TTR patients, hereditary and wild type?
I would start off by saying, you know, talk to your healthcare provider, talk to your doctor first. I don't see, I mean, for my patients, I haven't seen anything yet that would make me more or less concerned about any of these vaccines for amyloid patients versus not patients without amyloidosis. I think, you know, the data shows that any patient with chronic disease, and certainly older patients, are more likely to do worse with COVID. And so I would say that most of the patients on the call are probably older folks with chronic disease, obviously, and so they would be in the higher risk group. But I haven't seen anything specifically that would make me, you know, think about patients with amyloidosis differently than I would think about general patients who are older with chronic disease.
Thank you. And Dr. Karam?
Muriel, I think next time you should just invite Dr. Fauci to the meeting and ask him these questions. But yeah, I totally agree. I mean, I think definitely the people with amyloid are probably at a higher risk because it's an underlying condition, and a lot of our patients are older. You know, I think the vaccine is going to be important. Now the FDA is reviewing it, and if everything looks solid and there's no safety concerns, I think eventually most of us are going to get it, because if only, you know, 20 or 30 or 40% of the population get the vaccine, it's not going to work. So eventually, I think, and that's from the infectious disease expert, what they say, really most people in the world need to get the vaccine for it to be effective. That's the reality of it. But if you can get Dr. Fauci, I'll be very impressed.
I was going to say, I don't know if Adam's still on, and he can comment across departments on Pfizer.
Adam, he had to leave. But, you know, does anyone else want to make a comment about the vaccine? No?
Well, Muriel, Just a comment about the trials. We are instructing our patients to, if the attending physician can offer him a vaccine that is approved in the region, in the country, there's no problem for us. We are instructing them to follow the physician's orders. Nothing that we believe that would be a problem for clinical research. The other way around, the more we protect the patients, the better.
Thank you. I can only give you my opinion, which as soon as it's available, I will be clawing my way to be first in line. I'm tired of living with this, over my head, worrying about everything, and I won't be flying to do any meetings until everyone at that meeting will be shot up with the vaccine, just so you know. Okay, I want to thank you all so much. Our panelists today were extraordinary, and some of you, I know we didn't hear from you, but there were more than one representative from the companies, and we loved having these new faces at our meetings. Our attendees, we still have 179 hanging on. God bless them, they're wonderful, okay. Bob and Paula and Tracy, we thank you. Bob and Paula will make this available on our website in, let's say, 2 weeks. If it's sooner than 2 weeks, keep checking amyloidosissupport.org. And if it's sooner than 2 weeks, that's a bonus. But don't start emailing till at least 2 weeks are up. Okay, and we'll announce future schedules via our Facebook group and our website, One Amyloidosis Voice, and all the other social media that we take part in. We want you to stay safe and let us know if there's any questions we can help you with. You know that the email info@amyloidosissupport.org is always available to you. Our telephone line is always available to you, night or day. We do prefer day, but it's always available to you, okay? And don't forget the survey when you leave. We really appreciate you filling it out. And we thank you all so much. I promised Paula that this was going to be a short one, and oh, Paula, I lied. Okay, thank you all. Take care now. Bye-bye.
Thanks, Muriel.
Thank you, everyone.